partly because you're victims of our own success, because you're heavily oversubscribed to today's conference. But so anyway, you're very lucky you're all here. I was mindful listening on the radio coming over that our king and queen, when they arrived in Australia, were having a rest day. Here you all are. You could be having a rest day at home, tucked up in bed, instead of which you wave the storms and floods around you and coming from. So I hope this day is going to be the exciting day that we wanted to be for you all. And of course, these days are always made by the people of the tongue. So one of our great joys is to welcome you all to this conference and hope that you have an enjoyable day. My name is George Redden. Pleasure to welcome you all here today. Particularly those of you who've travelled a long way. I know some of you have come a very long way to be here, both physically here and indeed on Zoom. And welcome to all of those who are with us on Zoom. You're very much with us, and my apologies in advance if I don't address you directly on camera, but you are very much with you, and we very much value your contributions, and we hope that we will be able to hear more from you as the conference progresses. Today's very international conference adds to that narrative, being entitled Reaching Those Most in Need, Thinking Globally and Acting Locally. So a very warm welcome, and thanks to all our speakers for sharing their varied experiences and considerable expertise. And above all, they're thinking about making this connection between what we know the need to be for palliative care and delivering and caring for those people most in need. You will hear today lots of encouraging and good news and inspiring news about what's going on, what's actually being done locally in different settings with often very limited resources to reach those most in need. But we're getting the conference underway by looking at the big picture, where palliative care sits in universal health reforms. And it's our view that no one is better placed to take us there than Robert Yates, who's kindly accepted our invitation to deliver the keynote address. His work on universal health reforms and universal health coverage is widely recognised as groundbreaking. He's written extensively on the subject, been consulted widely both nationally and internationally. And I commend to those who haven't read it his report for Chatham House published last month, Driving Universal Health Reforms Through Crises and Shocks. Well, I won't know this, but I first heard you talking in 2016 at Britannia Street. Gosh. Yes, gosh. When this phrase, it is not universal health coverage without palliative care. Notwithstanding, though, the economics about which I know you'll be talking, I submit that without a commitment to integrate palliative care training and education into health and social care systems, there can be no sustained palliative care. So it's a great pleasure and a privilege to welcome you, Robert.
Great. Thank you very much indeed, Josh. That's very kind of you for inviting me here today. I'm absolutely thrilled to be with friends and comrades sort of campaigning for palliative care across the world. And I've been delighted as I've been sitting here watching people join from Ghana and Nepal and Tanzania. I saw, all countries where I've sort of been working in recent years. And I know that this is a huge issue. These are all countries looking to extend their health coverage. And I think it's so important that we sort of look at tactics, to ensure that palliative care is included in these universal health reforms. So this is very much the topic today. And I'm keen that this is interactive. I don't want to just do a lecture with loads of PowerPoint slides and bore you, Richard, sort of that we have a discussion about this and that this is very much a sort of a lesson learning about tactics, sort of political tactics that we might use. Because at the end of the day, a lot of the allocation of scarce health resources, I'm sorry, not really see particularly well there, can you? Try to sort of move around a bit here. Everyone's still saying, it's a very political this, and that we have to engage in this. So what I'm suggesting is that our best tactics are to be sort of seen to be fighting for the palliative care cause within universal health reforms, which is very much sort of recognizing that we want a system whereby everyone gets all the health services they need with financial protection. And that in many respects, what we're trying to do is fight for a much bigger cake that we can sort of share out to make sure that palliative care gets a bigger slice of that cake, as opposed to just accepting what we have at the moment and sort of competing against maternal health services, mental health services, so it's like united we stand and divided we fall. And I think that universal health coverage, which I suppose as a sort of a brand really has only been around sort of for 15 years or so, I think has captured the imagination of politicians all over the world. You have high-level meetings at the United Nations, you have sort of great reports written about it, and every country signed up to this now as part of the Sustainable Development Goals. And this is a definition of the WHO that you can read here, talking about everyone getting all the health services they need and being quite specific about it being promotion, prevention, curative rehabilitation, and palliative care. And that was quite a battle to get that in. Because initially it wasn't, but now it is in the official definition. But as well as people getting the services, that in accessing services, they aren't plunged into poverty, they have financial protection. Something that we're very familiar with, we're very lucky to have in the UK, but it's certainly not the norm across the world. But every country is striving towards this goal. And don't worry, I'm not going to do too much on sort of the UHC theory and stuff like this, but the point I'm making is that it's really based on values of fairness and equity, that we're talking about literally everyone on the planet. No one should be left behind. Homeless people shouldn't be left behind. Refugees and migrants shouldn't be left behind. Everyone should be covered by this. No one should be left behind. And that we're talking about services being allocated and made available according to need. And objectively, some people need more healthcare than others. And can you think of a group of people who need more healthcare and support than people with life-limiting illnesses? I'll come on to that in a moment. If we're going to have this system with everyone getting the financial protection, logically, it's got to be financed according to people's ability to pay. So basically, rich people pay a lot more into the system than do poor people. And so it all boils down to a universal health system, meaning that healthy, wealthy people cross-subsidizing services for the system. I know to a lot of you this is very, very standard. But as I said, this is not the norm across the world at all. And quite a good way to think about this conceptually, and this is WHO that who initially did this as a box. This is the World Health Report of 2010. And I think it sort of shows you that governments and societies are looking at this across 3 dimensions. And what you want is to fill this box so the entire population is covered with all the services they need with full financial protection. But in this sort of diagram here, you've got a country that's sort of like halfway along each dimension. And then, so the question is, if you've got limited resources, do you sort of try and cover everyone, but maybe with a narrow benefit package, or do you sort of say we can only really cover a small group of the population, but we're going to give them a lot of services? And how much do you protect them from the costs? And how you move is very, very important. And one of the points I'm keen to emphasize is that if we're serious about this being universal, then you really must prioritize population coverage. You cannot have systems whereby great swathes of the population get left behind. And I think that's been made, doubly apparent with obviously the recent pandemic, that just had how wrong that is. But these are the big decisions that countries have to make. And I will mention, of course, that a lot of this is around financing. A lot of this, because there are some very, very wealthy countries that don't have universal health coverage, and the most famous being the United States. It's crazy. 18% of GDP spent on its health system, and so about 30 million Americans don't get decent coverage. And I think what the US shows, and the 1 or 2 other countries show this as well, is that a market-based system where people buy and sell health services like other services will never reach universal health coverage, because basically only the rich will get them. And if we're talking about a system whereby the healthy and wealthy subsidize the sick and the poor, the state must get involved in that. And one might like to think that charity would do the job, but at scale it just won't. And so the state must get involved in enforcing this. And really what we're therefore talking about is a publicly financed health system. And so looking at sort of countries that are moving towards universal health coverage, the focus must be on domestic public financing. Now, aid financing plays a role, don't get me wrong. I mean, I spent a big chunk of my career in DFID, and the likes of the World Bank and the WHO are doing great work, but in big, low middle income countries, you can get Bangladesh population 160 million. Yeah, it's really, aid financing is domestic financing. But getting more domestic health financing is a very, very political process. And, we're seeing this, wait for the budgets in the UK in a couple of weeks, how is the NHS going to fare? It's very political. So we have to get involved in this. And just to emphasize this was Gro Harlem Brundtland at the UN high-level meeting. So the former Prime Minister of Norway and the former Director General of WHO saying if there's one lesson the world has reached, you can only reach UHC through public financing. So the question is, how do we get more public financing for UHC? And specifically, how do we get it for palliative care? And this is where I sort of switch it to, like those of us who care and are concerned about palliative care, what are our arguments that we should be using in these types of debates? And just to state that, the blindly obvious, that people with life-limiting illnesses are a high-need population group who need a whole range of health services, and a lot of those will be quite expensive, particularly in low income settings. A lot of people, that in this situation will have no access to financial resources. I mean, in some countries where they don't have a universal health system, they might have bankrupted themselves, in their treatment. So they're a very, very key population group who need this. Again, to state the blindly obvious, I'm talking about patients to be converted here, these are very, very cost-effective services, huge impacts on people's lives, their families' lives, and future generations. So the cost-effectiveness argument is very straightforward. So these combined, this should be a top priority for universal coverage, and therefore, the getting public financing. But I'm not necessarily saying that the services have to be publicly provided. And of course, that we know that so much of the hospice network, is a sort of a combination of sort of the voluntary sector, and we're getting big subsidies in some countries from the state. So, and this is true across the world. There are health systems where actually the majority of the providers, not just for palliative care, are actually in the private sector, but you have the government purchasing services on behalf of everyone. This is a system in Japan and France. So it's not necessarily the case that all services have to be publicly provided, but public financing is absolutely essential. And in preparing for this, I just picked this off the internet the other day. We're aware that we've got a change of government in the UK. That one's hoping we're going to see sort of a much bigger investment in the health system, but the hospice sector very wisely are pitching to West Streeting and the Labour government, we need more financing. And I think, I'm sure, lots of people in the room involved in hospices here in the UK are recognising, that we need more public financing, because despite all the wonderful charitable work that's done, it's not enough, and we need more financing. So this is true in the UK, and believe me, this is really true across the developing world as well. And I just want to briefly mention how I got involved in this, really, because my first experience working overseas, I'd been an NHS manager, but was in managing a community-based hospice in Eswatini. Back in those days, showing how old I am, it was Swaziland Hospice at home. And I just want to almost like use this as a little case study, because this was a hospice set up by a British cancer nurse. And it was very much focused on palliative care in the community setting, going out into homesteads, helping families care for their loved ones. And it was a fantastic model, and it was exclusively funded out of charitable donations coming from the UK, particularly from South Wales, but also trying to raise money locally. I was recruited as a general manager, but I soon found myself doing 90% fundraising. And I must say that we nearly went bust. And we just could not get enough money. We were trying everything to get money out of the local businesses. And also in the mid-90s, when I was there, the caseload suddenly changed from being predominantly cancer patients to AIDS patients. You know, it was the absolute high point of the epidemic. And you know, this was the type of care that was being provided, going into people's homesteads, providing them with medicines and with food, very, very cost effective. But I mean, the workload was just astonishing. And we realized we needed a lot more funding. And we were successful in being able to get some British government funding, particularly tapping into the AIDS monies. And you know, that we very much pitched ourselves that, and tactically we were doing this. We weren't exclusively an AIDS hospice at all, but we were dealing with this huge storm of enormous impact on the health system in Eswatini. And it was very successful. We were able to get quite a lot of funding. We expanded to some extent, but we knew that this was not going to be sustainable in the long run. We needed to get domestic public financing. And one of the tactics that we employed was to very much sort of recognize the makeup of society, and to really sort of tap into the royal family. And this is our patron, Nkosikazi Langangaza, who was a very popular wife of the king. And she really took it upon herself to champion for palliative care and the hospice. And it was really through her that we were able to get lots of government financing. And I must admit, I've rather lost touch. It was so many years ago, but I just looked up the hospice the other day, and it was very interesting that it now says that it's a government of Eswatini initiative. And I was so pleased. I mean, you know, this all happened after I left, but this sort of strategy of, you know, we started with aid funding, but now government funding. And I pull this off the net as well. You know, the hospice and all their supporters are really championing palliative care within Eswatini. So you know, this I think, you know, sort of works as a model, and I would like to think that it's on sustainable financial footing now that it's getting government funding. So how do we do this then? What are the sort of the tactics that we might employ that, say, as a country is expanding coverage, is looking at maybe raising some more money? What should we be doing? And these are just sort of pretty obvious suggestions, really. That this is where we do need all the sort of the fantastic evidence and research, you know, to show the impact, the health impact it has on households, the economic impact it can have as well, you know, reducing the burdens on, you know, sort of households. Use all the best research, but dare I say it, you know, to get it to the most important people, who are the policymakers. And to some extent, it's not really good enough to get it into the medical journals. You've got to get this in a digestible form that the Minister of Finance and the politicians really like and understand. This was sort of more for I took this slide as sort of a global conference thing, that if within the universal health coverage monitoring globally, there isn't actually a palliative care indicator at the moment. There are indicators about babies born in health units and you know, sort of proportions of people getting vaccinated. But if there were a good agreed palliative care indicator that we could hold governments to account on, that would be quite important as well. Blind in the obvious one, get political. You know, that I know people often don't like getting involved in politics, but really, you know, we have to, and you know, form alliances and get to the politicians. You know, that's why I think the movement is very smart at the moment, so trying to get to the new Labour government. And fight injustices, and you know, fight hard for them. You mentioned the great Lancet work that Julio Frank and Felicity Moore, people like that were doing. I mean, some of the statistics in that are just unbelievable, and you know, and particularly pointing out the ridiculously low cost of providing analgesics, you know, for children. I mean, it's just nothing in the sort of global context, and really sort of beating politicians over the head with this. And you know, to some extent, where obviously families are happy to do this, take it to the media and really embarrass populations into governments into taking it more seriously, and take it as an opportunity to promote palliative care at the World Health Assembly, at the UN, at all these sort of fora. I mean, there's been, just last week, there was the World Health Summit in Berlin. I didn't go this year, but I don't know to the extent to which palliative care was being discussed there. And there are people doing this, sort of the dear Lucy Watts, great campaigner for palliative care. She approached Tedros, I think initially through Twitter or something, and sort of that when he came over to London, he met her, and he was very. I spoke to Tedros about this, very, very touched with her and her approach, and he has been engaging. He has been dealing directly with the community, sort of trying to sort of have discussions, and he, of course, at his level, engages with political leaders. This is again something that sort of he wants to talk to politicians, and so if we can get to the likes of Tedros, and if he has a discussion with an African president or something, this could be a good route. And this is something that we and I have been sort of specialising in, and until July I was working at Chatham House. I'm moving to the LSE now, but we set up a commission coming out of the pandemic, and quite simply, it was to pitch universal health reforms to politicians in a time of crisis, recognising that so many of the world's great universal health systems, weirdly, have come out of crises. The NHS came out of the Second World War. Same in Japan, same in France. Thailand launched its universal health system after the Asian financial crash. So we were very much thinking, well, let's almost like use this crisis to pitch to politicians that now is the time for them to launch their equivalent. And we had the former Prime Minister of New Zealand, Helen Clark, was one of our co-chairs. This is the former President of Tanzania, Jakaya Kikwete, very keen to have this discussion with leaders. And the lady on the panel with me is the former Ukrainian Minister of Health, who launched universal health reforms after the first Russian invasion in 2014. So we were very much looking at the tactics that you might employ to use this opportunity to pitch for UHC reforms. And, I think that the state of the world at the moment is an opportunity because, the pandemic is one crisis, and we're in polycrisis at the moment, with all the conflicts in the world, the climate emergency. There is a feeling of crisis in the world. Politicians are under pressure. The pandemic really did expose health systems. I mean, it did the UK, if we're being realistic, and my goodness, it did the palliative care network as well. I mean, a good number of you will have been involved in that, and that must have been just horrendous. So, people are very conscious this in there, and one of the most emotive things was people not being able to be with their loved ones at the time of greatest need. So, this is a great opportunity to do this, and we did get a lot of media attention, through the pandemic. So the world is in this state of crisis at the moment. There is this history of leaders saying, right, now is the time for us to reform our health system, and many countries are thinking of doing this. I mean, we're working in Bangladesh, Tanzania, through the president. We're very aware that's how Nepal. I was in Nepal earlier this summer, and they're thinking about doing this as well. So there is this great opportunity, and as I say, when it's done properly, it's always associated with big increases in public spending. Usually in the order of about 1% of GDP is enough to really sort of make a big start. So that's quite a lot of money. So we mustn't miss out on this. Where might we look to? Well, I mean, Sub-Saharan Africa, I think, is very interesting. And this is the president of Rwanda. He's talking after, in the midst of the crisis, President Kagame. And he was noting, basically how the West were letting down the developing world. Let's face it, we ran off with all the vaccines, we were stockpiling, and then we didn't fund the multilateral system properly, and we were even blocking tech transfers to developing countries. And a lot of leaders were furious about this and were sort of as chair of the African Union, he was saying, we're going to have to do this ourselves. If we're serious about this, we're going to have to do this ourselves. And Rwanda does have a pretty good health system for its income level. I mean, it has prioritized universal health coverage. But there are countries where this is happening in real time. I'm not sure we have anyone from Kenya either online or is it online. Well, you can keep us up to date. I mean, if I'm not mistaken, their latest UHC reforms were launched on October the 1st. And this is the health secretary talking about sort of, encouraging people to sign up to the new reforms. They'll be putting more public financing. And my understanding is that palliative care was explicitly included in the package. And that's great. That's really great. But you've got to hold them to account. So it's all very well and good just putting palliative care. Where's the budget line? Where's the money going? South Africa. Anyone from South Africa? Again, this is happening right now. Just before the election, the president signed the NHI bill into law. The NHI is very similar to an NHS in its design, but there's an almighty political battle going on in South Africa at the moment. Dare I say it, with people in private medical schemes fighting tooth and nail to oppose this. I mean, it's equivalent to the United States. It's trench warfare at the moment between finance and health and the medical schemes. Will they launch this properly? They've been trying it for the last 10, 15 years. And how much will palliative care be included? Watch this space. I don't know yet. Just to sort of wrap up, universal health coverage, achieving universal health coverage is highly political, particularly this financing, who pays what, who gets what. But the nice thing about it is politicians get it, whereas a lot of the terminology we use with politicians, they don't really understand. Everyone gets this idea that everyone's going to get health service and the government will pay for it. Within that, end-of-life care is a very, very emotive issue. People do care about this, and it affects everyone, obviously. So making sure that palliative care gets a decent track of the work in itself is very political. So what we need to do to get this slice of the cake that we deserve, yes, we need technical solutions to be as efficient and effective as possible, but we need political strategies everywhere. We must therefore be looking at the way we sell that. And I think, therefore, it is about selling the benefits to its politicians, selling the health benefits, and they're pretty self-evident, the economic benefits, the benefits to society. But the funny thing is that the benefits that we don't sell the most are the political benefits. This will get you votes, this will win you power, this will make you very popular. And I think that's where we need to be at, really. And you mentioned the slate, and this is something that I've heard Tedros say, if it's not universal health coverage, if it isn't including palliative care. And this ought to be our sort of mantra, really. So that's it, really. And I'd just say I tweet on this stuff incessantly, so this is a rather pathetic way to increase my Twitter followers. So if you're interested in this type of stuff, please do feel to follow me. But and we'll happy to answer questions.
Thank you very much.
Thank you very much indeed. There's so much that you could talk. No situation. I get it. There's so much that we could pick up. I just wanted to pick up on one thing, which is that it affects us particularly. That's access to funds. Yes, the donor draft, because you've got this wonderful program that you're proposing here, and yet we are being asked to deliver palliative care training and education, and there's no money.
Yes.
Have you got some?
It's really tough out there at the moment, and I think that we are seeing international aid financing for health going down very, very fast. And it's shocking. What one would have thought, wouldn't you, that the pandemic would sort of make the case much stronger. But if you look at our previous government, they took that as an opportunity to shut down DFID, cut aid financing for health, and I'm showing my political colours here. I mean, that was just lamentable. They've got away with it. And people weren't demonstrating about it. So. My general view, we're not alone in doing this. Japan and Sweden and Germany, they're all cutting their health financing. So in many respects, I mean, I suppose what I'm saying is that it's absolutely essential we switch to domestic financing. You know, it's not to say that here in the UK that we can get aid financing. We're talking about leveraging domestic financing. I mean, this is a lot of the arguments that we're using with the LSE is that a lot of these countries now, they do have the resources to pay for themselves, but you know, they need to sort of get going on this. And so I think that there is this case for using aid financing to leveraging domestic finance in these countries. And that could be like in Bangladesh, you know, that getting the government to pay more into palliative care. So I think there is limited funding, and maybe some of these arguments will help, but we can't kid ourselves that we're going to go back to the good old days.
Can we take some questions from?
Thank you. The people in the room upstairs are struggling to hear us, so they just asked that we use a microphone or pitch. And no, I think it's just for the questions.
Yeah.
Absolutely. So, question coming from Dan Monday, who's joining us from Nepal, and Dan asks that he states Dr. Tedros has stressed that universal health coverage is only possible through a primary care approach. There's a special issue on primary care in palliative medicine, which is a journal, Robert, you won't be familiar with, I imagine. Do you have any advice on how to link palliative care to moves within primary healthcare movements and advocacy on a global level?
Yes, and that's an excellent question. I'm delighted that you're calling in from Nepal, actually, because I was there in, I think, May or June, and sort of very aware that, you know, the government has sort of got plans to extend health coverage there. And I think, again, this is one of our tactics, really, that we do form alliances with movements that particularly the primary care movement, and, you know, to ensure that more money is put into primary care in general, and palliative care gets more funding. And one's aware of a number of countries that in moving towards universal health coverage, that their models are far too dominated by big tertiary private hospitals, particularly India. You know, sort of, apologies to any Indian colleagues in the room. And I think that this is actually having some spillover effect in neighbouring countries as well, and that a number of the health insurance programs being designed in Nepal have a big focus on hospital coverage, and Modi's reforms in India really only cover inpatient hospital care, and they're not covering people for the cost of medicines in primary care and stuff like that. Now, I'm aware in India that there are certain state governments that are taking a very different approach, primary care focus, universal access to medicine, big emphasis on medicines. And this is a political battle that's being fought. The Delhi state government and the Punjab government are in particular doing that. I think, you know, these are the people we need to be allying with and showing that it is possible, and looking to neighbouring countries that have adopted a primary care. Thailand, not that far away, got a fantastic universal health system, and it's very much focused on community health services. Palliative care is involved. So I think maybe learn some lessons from the success stories in the region, of which Thailand's very good.
Thank you for that. Are there questions from the floor? Paul here, yes, first.
Paul Myers from Starlight Oasis of Hope Hospice Institute. Thank you very much, Rob. Very challenging, but also quite reassuring, because we're at the early stages and we're doing some of the things that you're saying. But there were two things very closely related that I just wanted to ask about, and that's in terms of influencing politicians. And I really liked your idea of telling them that it buys votes, because that is a winner. But my concern is, one is about actually how do you sell the economic cost effectiveness of palliative care, and the other was a slight worry when you said embarrassing politicians, because we need the politicians on our side. They could stymie everything we do if they wanted to. So how do you, what's the appropriate level of embarrassment to aim for?
And that's tricky. I mean, these are the dark arts of the politics, and you know that dare I say, what we're seeing at the moment in the run up to the UK budget is all the spending departments are basically leaking stories to the press about, you know, the state of the NHS, and you know the army's running out of tanks and stuff like this. You know, as a former civil servant, these are the tactics you employ. stuff miraculously ends up in the press, and to put subtle pressure on. Now, I'm aware of some situations that, one, for example, of health systems whereby, because of very high user fees, people who can't pay their hospital bills are hit with these massive bills. And if they can't pay them, they're not allowed out of hospital. They're locked up, incarcerated in hospitals for months, if not years on end. I mean, that is an absolute terrible human rights abuse. And the Human Rights Watch did this really, really powerful report in Burundi, basically showing that the hospitals were like debtors' prisons. People were being locked up, and particularly women who had had cesarean sections. This was very, very hard hitting. And you can imagine, embarrassed a lot of people, not least the president, who was horrified actually to find out this out. He didn't know it was happening. But then, really off the back of that report, released all women and children from hospital, and then introduced universal free healthcare for pregnant women and children. So that might appear a rather sort of brutal approach, but it works. The trick is often to sort of be working behind the radar, encouraging that sort of stuff, but perhaps not having your fingerprints all over it. That when the minister gets embarrassed, that they say, "Well, this is your fault. This is on the front of the papers." So it's tricky, but I think given all our networks and engaging the media, bringing them in, and sort of putting some real sunlight on some of these things going on, and to your first question about the economic benefits, I think it is again smart to package it up with investment in health overall. The primary care as well. Now there might be some sort of particular arguments around, that if you can provide end of life care, well, obvious ones that if you can encourage people to leave hospitals and then be cared for in the palliative care setting at home, that will save money and free up hospital beds. They often like things like that, and also the likelihood it's going to reduce impoverishment of households. Particularly if you're providing sort of medicines and things like that, that households aren't going to go bankrupt at the time that they lose a loved one. So I think it's trying to get into the head of the politicians about where they're coming from, and I mean, what we did in Swaziland, and I'll be quite upfront about how did we engage more with the government. What we did, we organised big brides, we organised big parties, so barbecues, sort of that we would invite cabinet ministers to, and enable them to rub shoulders with our patron and stuff like that. So, and we used local businesses who provided us with the beef and the beer and all this type of stuff. So we sort of got known in the NGO world, bizarrely, as a bit of a party. We had this massive fields where we could do this. We didn't really have any buildings at the time, see. So we had this resource, and we were slap bang in the middle of Eswatini. So it was quite a long process, but it paid off in the long.
I think we've just got time for one more question.
Hi, I'm Beatrice. I want to give a little bit of context of my country for popping the question. I'm from Mexico. In Mexico, we have a law for palliative care since 2009, and we have some norms that make it mandatory. But what happened afterwards in our health system is that we have some checklists or indicators that, okay, if you want funding for the hospital, you need to have this, and that. One was palliative care. But then what happened was that they will just pick someone randomly. So sometimes someone who's not even trained, and okay, you will do palliative care. So they get the accredited certification, they will get the money, and then palliative care won't change. So right now, what we're struggling is that we have really strong law in Mexico. Our normative is really one of the strongest in Latin America, but it's not a reality. And my question will be, because they use us a lot, like when we go and knock the doors of politicians, they take pictures with us. We got invited to the Senate, and they're like, "Oh, we're working in palliative care." We get excited, and then nothing happens. My question would be how to try to go around it and to make it a reality.
And that is about holding people to account on this type of stuff. And we know that politicians love them all loath, and they will game system. They will obviously sort of try and show that they're doing great things, but they will often not deliver. My goodness, is that true of universal health coverage? You know, the number of times I hear people at the UN stand up saying, "Oh, we've got universal health coverage for everyone," and it's just a lie. You know, there are people locked up in hospitals who they can't pay the bills. So we need to hold them to account, and I think this is where civil society plays a big role, and the media plays a big role, and you know that where that there is this commitment and it's not being fulfilled. This is where, to some extent, you embarrass them, and say, "Well, this isn't happening. This is a lie." It's tricky but then again, because of the people we're working with, I mean that's a really scandalous thing for politicians to leave these people out in the cold, and they need to feel that pressure. But then again, things like indicators I think are quite important, and say, well, what does commitment to palliative care mean? Sort of what does that mean in terms of numbers of practitioners, their level of training, access to medicines is an obvious one. I think that is the most obvious one, showing that people are dying in pain and because they're not getting very, very cheap medicines given to them is, red card. So that's terrible. And you just find things that really, in the public's mind, will help them realise this is nonsense.
I'm very sorry, but I'm going to have to say there are no time for any more questions, but I know that you'll be available at a great time to answer any more. And thank you very much indeed for
Thank you.
inspiring. I mean, we could spend all day, but
And the end of the morning, yeah,